moving towards third session, I would like to call the chairperson for the third session. The topic is management of chronic lung disease. And the chairperson, Dr. Dheeraj Kishore, sir. Dr. Vikas Agrawal, sir. Dr. Amit Johri, sir. Sir, आप please recite. Dr. Dheeraj Kishore, sir, Dr. Vikas Agrawal, sir, and Dr. Amit Johri, sir. Next topic is management of chronic lung disease.
Good evening, everybody. It's always a pleasure to introduce Dr. Rajadhar. And Dr. Rajadhar is a well-known person who does not require any introduction. But for those people who are new, I may like to say a few words regarding this. He did his MBBS, MD from Calcutta, and he did his FRCP from UK, London. He did his MSc in Evidence-Based Medicine, UK. He did CCT, Respiratory and General Medicine from UK. His FCCP, FICS, Diploma in Palliative Care, Newcastle University, Certificate in Education, Teesside University. He is Director and Head of Department, Pulmonology, CK Group of Hospitals, Kolkata. He is Director, Research and Education, National Allergy, Asthma, Bronchitis Institute, Kolkata. He is Director, Hermes Exam Asia, European Diploma in Respiratory Medicine. He is Director, Asia Pacific Alliance for Control of Influenza. He is Joint Secretary, Indian Academy of Allergy. He is Founder Member, Southeast Asian Academy of Sleep Medicine. He has 157 international and national publications in index journals and abstracts along with 21 book chapters. He is a lead author for Embark India. He is associate editor for Respiratory and on editorial board for multiple other journals. He has been awarded with Dronacharya Award for Excellence in CME in India. Indira Gandhi Gold Medal for Outstanding Individual Achievement in Medicine. He is coordinator of DNB course for the last 8 years, and he started first DNB respiratory course in Bengal. And there is one more thing which is not written here, which I know, that he has represented his state in badminton.
Thank you, Johri Sahab.
With all of these credentials, the big credentials, I would like to mention few of his recent publications published in the Lancet as well as European Journal of Respiratory Medicines, and those were the bronchitis in the India, results from the European multicenter bronchitis adults, the IMBARAC. And another one, the Clinical Practice Guideline Indian Consensus based on the recommendations on pneumococcal vaccinations. So you can understand is right from the not only the chronic disorder of respiratory, along with in the every area of the pulmonary medicine, he has got the masterio. So please listen to his deliberations.
Thank you so much. Thank you very much. I'm really touched, a bit embarrassed, but thank you so much. Always a pleasure to come and speak in Varanasi. I'm sorry, the title of my talk is wrong. I started off thinking that I would talk about asthma and COPD, and then Pathak Saab, who's very kindly invited me to every of his meetings, asked me to also speak on ILD. I know we are running short of time, so I'll try and do this in half an hour. Bear with me, and if I'm running over time, please tell me and I'll stop immediately. So that's what is on the anvil. I'll talk a little bit about these individual diseases. I'll talk about chronic obstructive pulmonary disease, about asthma, and about ILD. And I'll do that in the perspective of cases, presenting the current guidelines in the perspective of that particular case. So let's start off with what is probably the most important challenge for us in the chronic disease scenario, not just in respiratory, but all over all global chronic diseases, that's COPD. So when we think about the global burden of COPD, the prevalence in men is 11.8% of the global population. 11.8% of the global population, and more importantly 8.5% in women, which is a sharp rise from what it was 10 years ago. If you look at non-smoking COPD, which is, like I said a little while ago, a bigger challenge in India, it's above 3% of the global population. So large numbers, but the impressive part of COPD as chronic respiratory disease is the mortality. And you can see the numbers there. The death rate is 4.72% of all-cause mortality, which is second after ischemic heart disease, and third is other airways disease. So lower respiratory tract infection comes in third in that particular list. So 3 million deaths globally is what we are looking at when we think about COPD, and that's the global burden of disease data from 2019. This is what we were speaking about a little while ago. 2005 rankings versus 2016 rankings for the commonest causes of death. And I'll use my cursor. I don't think the slide pointer shows up well, but you can see COPD at third about in 2005, gone to second now as the largest killer of various diseases throughout the world. What's the number of years that are lost from COPD? For a 65-year-old man, you can see if you've got mild disease, stage 1 disease, you lose less than a year. But as soon as you get to moderate disease and then to severe disease, it's close to 6 years of your life that you lose. And if you're a current smoker, so that 3.5 is current smoker. If you're a current smoker, or if you have a past history of smoking of more than 20 pack years, you add in another 3.5 years of life lost in that gambit. So 6.5 plus 3.5, so that's about 10 years lost if you are a current smoker and if you have smoked beyond 20 pack years. A little bit about the disease trajectory and what causes COPD. I want you to look at the green line first. The green line shows you the normal decline of lung function over a 25-year period. So that's the normal decline of lung function. If you look at the red line beneath it, you can see decline of lung function starting at around the age of 30. And the red line dips downwards sharply, and that's the 6 years of life lost when we talk about patients with COPD. So these are patients who have smoked or have an environmental trigger like biomass or exposure to incense stick, air pollution, etc. That's the dip that you see in patients with COPD. Look at the orange line next. That's another cause of COPD. That's COPD because you are born with small lungs. So it's small fordate lungs where the decline of lung function is less precipitous, but you end up with the same level of lung function after 50 years. So two causes. One is environmental triggers resulting in decline of lung function. So we spoke about smoking, we spoke about biomass, air pollution, incense stick, all of which causes non-smoking COPD. And the second is small fordate lungs, which we are born with, that results in decline over a period of time. Both result in similar decline. What's the proportion? So about 70% of COPD is caused by decline due to environmental factors. About 30% is due to small fordate lungs, which causes COPD. This is from Gold, and this looks at etiotypes of COPD. So that's a new terminology. It was a new terminology for me and maybe for most of you. This helps in classifying COPD into various categories. So you can see, I won't read through all of them, but this tells you that when we did medical school, we were taught that the only reason you could get COPD is by smoking. So you start off by looking at genetically determined COPD, which is COPD-G. Then you look at abnormal lung development. So that's the alpha-1 antitrypsin deficiency, etc. So that's COPD-D. Then comes the environmental factors, and we have spoken about these. COPD-C is from cigarette smoking. COPD-P is from biomass and air pollution. COPD-I is from infection. That's an important category in our country. If you have TB, and even if you have full treatment, post-TB over a period of about 5 to 7 years, you start getting a precipitous decline in lung function and you behave like you have obstructive airways disease akin to COPD. So we are just about to publish our data from a 20-center study on TOPD, which shows that the decline is impressive and it carries over up to more than 10 years. So that probably makes us think. There's a lot of people who do advocacy, there's people who treat TB, who make guidelines for TB, and maybe follow-up of TB even post-cure is something that we need to incorporate in our guidelines going forward, and that's an important point to remember. So COPD-I, COPD-A is the overlap of asthma and COPD that we spoke about before, and then you have a category which is always there in all chronic diseases, which is COPD-U or COPD from unknown causes. So this is what I'm going to do in the COPD ambit over the next few minutes. I'll start off with this case study. So this is a patient we saw not so long ago, a patient that you would see in your clinic. There's nothing great about this particular case, but tells you about the life history of a COPD patient, and we'll try and discuss them in the perspective of guidelines that are currently available. So this chap complains of breathlessness over the last 2 to 3 years. He's 58. He's noticed breathlessness for the last 2 to 3 years and has been worse for the last 6 months. He's worsened significantly before coming in to hospital. He's got a current exercise tolerance of 50 yards. He feels breathless on any incline. He feels breathless on walking upstairs just a few steps. His cough is worse in the morning. However, there's no change in character, and he produces thick, tenacious sputum, which he says is difficult to expectorate. There's no hemoptysis, there's no paroxysmal nocturnal dyspnea, he does not have ankle swelling, there's no chest pain. So those are all the negative history in this case. There's a family history here, and maybe this is something to think about. He's got a brother who has asthma. So now makes you think whether you need to go back into his childhood history, whether there were symptoms of allergic rhinitis, wheezing in childhood, and this could actually be an asthma COPD overlap, the A category of COPD that we spoke about a little while ago. However, given the fact that this guy does not have a childhood history, we'll treat this as COPD for the time being. And you can see he's got a trigger, the environmental trigger we spoke about. So he's a smoker of 40 pack years of smoking with occasional alcohol. So this is from Gold. And I want you to think of this slide in the perspective of the case that I described to you a little while ago. So these are symptoms which are thought to be important in the diagnosis of COPD. Symptoms which are important. So dyspnea, which is progressive, compared to intermittent dyspnea in patients who have asthma. It's worse with exercise and is persistent. This recurrent wheeze, even though again, this wheeze is persistent compared to asthma, which is intermittent. There's a chronic cough. There's recurrent lower respiratory tract infections, which is similar to what you get in this particular patient I'm speaking about. And there's a history of risk factors. And in this particular patient, that risk factor is a 40 pack year history of smoking. So coming back to the patient again, this gentleman is short of breath on moving from the waiting room to the consultation room. There are no other general abnormalities. He's not clubbed. He's got a tracheal tug. So for the youngsters, I don't know whether you're taught to check for tracheal tug anymore. But if you take the shirt off, if you look at the individual, you will see hyperexpansion of the chest, you will see indrawing of the subcostal region, and you would hear globally reduced breath sounds. So these were the investigations we did. And again, this is sort of for undergraduate teaching or maybe first graduate year postgraduate teaching. But if you see an X-ray like this, you think COPD, hyperinflated lungs, tubular heart, wide intercostal spaces, all of this equate to emphysema, air trapping, and COPD. This gentleman had a normal ECG. This is the cartoon of the flow volume and the volume time loop for this individual, and these were the numbers. And you can see on there FEV1 of 1.91, which is 62%, which represents moderate COPD. So again, the role of spirometry in COPD was something which was becoming a non-entity in 2022 and even before that. We wrote to Gold, we actually as a group wrote to Gold, talking about the importance of COPD outside the ambit of diagnosis. So till 2022, they would say that COPD diagnosis was only based on spirometry. The new COPD guidance, and we are proud to have a member from India in the Gold Committee now with Dr. Sandeep Salvi being there. So has come out with a list which is the role of spirometry in patients with COPD. Can be a little bit quiet, please? I'm getting disturbed. A little bit less of talking, please. Thank you. So the diagnosis is important when you're diagnosing COPD. Assessment of severe airflow obstruction is important. And then follow-up assessments, therapeutic decisions, etc. are important based on which spirometry is done on these individuals. So remember, for the juniors, the youngsters in the audience, it's not just for diagnosis, it's very important for diagnosis. You cannot diagnose COPD without doing a spirometry. But then assessment of airflow obstruction, follow-up assessments, especially when you do an intervention. So you heard Anshul talking a little bit while ago about mediastinal cryobiopsies. If you're doing lung volume reduction therapy of any nature, you would need a spirometry pre and post the procedure. If you're doing something simple like rehab, for instance, you would want a spirometry pre and post. And these are all factors that need to be remembered as indications for doing spirometry in patients with COPD. So the result of all these investigations, the history, the fact that this patient has a ratio of less than 70% and an FEV1 of 62% shows that this patient has an obstructive airways disease, and with no bronchodilator reversibility, this patient has COPD. The clinician that the patient went to initially also did a transfer factor, and the transfer factor was 61%. Again, for the juniors, if you find someone with COPD and you happen to do a transfer factor in these patients and it's low, it's one of two factors, and that's important to remember. So either these patients have predominant emphysema, because of destruction of the alveocapillary membrane, you get a lowered transfer factor, or it's an overlap of pulmonary fibrosis and emphysema, something which is called CPFE. So combined pulmonary fibrosis and emphysema. And here, something important to remember is these patients have preserved FVC, but a very low transfer factor. So if you see a spirometry which shows a preserved FVC, a very low transfer factor, think that on CT, you might see a combined pulmonary fibrosis and emphysema in these individuals. So what did we do? We recommended the importance of discontinuing smoking. We asked them to get vaccinated for influenza. We referred for pulmonary rehab, and we started these patients on an ICS and a LABA at this point of time. So this is a while ago. You wouldn't do that just now. For this patient who's relatively stable, you would actually start off with a LABA-LAMA combination at this point of time, rather than doing an ICS-LABA, which was what was done back in 2016. So these are the gold grades that you see. We spoke about 62% FEV1. So you can see mild, moderate, severe, and very severe COPD. Gold 1, so the ratio, remember, is always less than 70%, but gold 1 is an FEV1 of more than 80. Gold 2 is an FEV1 between 50 to 80%. Gold 3 is an FEV1 between 30 to 50%, and less than 30% is gold 4. This is the current tool for assessment of COPD. You can see it used to be A, B, C, D at one point of time. Now you have A and B, and then you have E. So we'll start with E. E is the exacerbating population of patients. So if you require 2 courses of oral steroids or 1 hospitalization in the past year, you get classified as the exacerbating population of COPD, which is called gold E. Gold A and B are based on the symptom burden in these individuals. So if you have less of symptoms and no exacerbations, you are gold A. If you have more of symptoms and no exacerbations, you become gold B. So going forward, I think the gold guidelines will have an S and an E, S being the stable population of patients and E being the exacerbating population of patients, because you treat these patients similarly. But that's sort of looking forward into the future. These are the vaccinations that are recommended for gold, and this is a major change in 2022-23. So in the 2023 guidance, we have gone beyond influenza vaccination, which is supposed to be an annual vaccine, and the pneumonia vaccination, where you have 2 different kinds of vaccine. One is the 13-valent vaccine, which promotes your humoral immunity, which is the Prevnar 13 vaccine, and then you have the 23-valent vaccine, which mediates your T-cell immunity, which is the Pneumovax 23 vaccine. These are now out of patent, so I'm telling you commercial names, and these will probably not be allowed in a few days' time. But as of now, these are the only vaccines that are available. However, along with this, there are other vaccines that are now required in patients with COPD, which you need to remember. So one is the COVID-19 vaccine. We still don't have guidance about COVID-19, but for healthcare workers, it's probably wise to take an annual COVID vaccine for the next couple of years, and hopefully the government or the ICMR will come out with guidance in these lines in the not so distant future. More importantly, there's the shingles vaccine, so the herpes zoster vaccine, and the whooping cough vaccine, which should be given to the at-risk population of patients. So patients who are above 65 qualify as being at risk, and the ones with comorbidities, the ischemic heart disease, the diabetes, the hypertension, and so on and so forth, they are the comorbid population where these vaccines should be given. So 5 vaccines: influenza, pneumonia, COVID-19, whooping cough, and shingles constitute the 5 vaccines that you need to offer to patients with COPD above a certain age or people who are comorbid. This is important. This is an important slide for postgraduates for their exams, but is also important for all of us. It's interesting to see that studies have mainly shown that it's the non-pharmacological agents which make a difference in mortality for patients with COPD. I'll say that again, it's important. It's non-pharmacological strategies which actually make a difference to mortality in patients with COPD. The first trial, which showed that there was a mortality benefit, were 2 different trials carried out in 2021 and 2022, which trialed the triple and found that there was a mortality benefit. So when I say a triple, I mean a LABA, a LAMA, and an inhaled corticosteroid. Aside from this, you got a list there: smoking cessation, pulmonary rehab, long-term oxygen therapy. You heard Dr. Pathak speaking about non-invasive ventilation. So non-invasive ventilation and lung volume reduction surgery are the modalities which are non-pharmacological, albeit one is surgical, but non-pharmacological measures which improve mortality in patients with COPD. Important to identify and reduce risk factor exposure, that's primary prevention. So smoking cessation when ventilated rooms. You heard people who were there during the press conference, heard a lovely little spiel about how you reduce exposure to things like fumes when you're doing puja, for instance. So all of that would come into reducing risk exposure in these individuals. That's pulmonary rehabilitation. That's something all of us need to do. As long as you give your patients an exercise prescription, it does not need to be rocket science. Even walking, climbing a few steps, doing upper and lower limb exercises, chest expansion translates into exercise and improves mortality in your patients with COPD. It reduces exacerbation, it improves mortality, it reduces symptoms in your patients with COPD. I'll skip a couple of slides and I'll go to the patient again. So this patient stabilized over the next 4 months, so stable COPD, we're talking gold B COPD here, but then had an exacerbation which brought the patient into hospital. Severe breathlessness, which had gone on for a couple of days, now was breathless in hospital on the hospital bed. Cough with yellow sputum, right-sided pleuritic, should read left-sided pleuritic chest pain, difficulty to sleep and swelling of the ankles. So this patient has progressed rapidly and now has cor pulmonale along with having COPD. Sick patient, respiratory rate of 40, central and peripheral cyanosis, tachycardic with a heart rate of 120, BP of 130 by 80, features of heart failure with a raised JVP, and muffled heart sound, which is more because of the emphysema rather than any other effect. And edema up to mid-calf, which punctuates the cor pulmonale I spoke about. And this patient has left lower lobe crackles. Let me show you the X-ray before I go on to the rest. So that's the X-ray, and you can see the left lower lobe infiltrates in this individual. So this shows you the classification of severity of COPD. So classification of exacerbations of COPD. You can see mild, moderate, and severe. This is the current gold guidance, and this was based on the Rome classification. Even if you don't read anything about gold from 2023, do this one particular slide, which I won't read out for the want of time. but see that between mild to moderate, there's a change in increasing of dyspnea, increase of respiratory rate, increase of heart rate, reduction of resting saturation, and a raised CRP. And between moderate to severe, if you develop acidotic hypercapnic respiratory failure, so as soon as you develop acidosis, respiratory acidosis, you go on to the severe category. So that's mild versus moderate versus severe. This is the first time ever in the history of COPD that an objective measurement for defining exacerbations of COPD has been given in a guideline. So we thought for our patients, so this is my 58-year-old gentleman, we thought this gentleman might have one of these 5. So those are the differentials: exacerbation of COPD, a pneumonia, pneumothorax, possible pulmonary embolism, and you heard about the overlap a little while ago when Dr. Pathak was speaking. So the overlap between cardiac breathlessness and respiratory breathlessness. So cardiac shortness of breath, maybe heart failure, maybe ischemic heart disease. So that is what you need to tick through when you see your patient with COPD coming to the emergency with breathlessness. It's not enough to take for granted that someone who's got a diagnosis of COPD has come in with an exacerbation. That's the checklist that you need to go through in these individuals. And this again is from Gold. This shows you the differential diagnosis that Gold talks about when you think about differential diagnosis for COPD. So you need to do a chest X-ray in everyone, and that's to exclude a pneumonia and also a pneumothorax. You look at pulmonary embolism, you do a D-dimer in these individuals and stratify risk in these individuals. And then you have less frequent causes like pneumothorax, heart failure, etc. And you're going to hear more, I hear, about NT-proBNP and the role in distinction between cardiac cause and respiratory cause of heart failure in these individuals. So these were the investigations for this patient, nothing to write home about. The chest X-ray I showed you a little while ago, but look at the ABG at the bottom there. So this patient has respiratory acidosis, pH of 7.29, PCO2 of 55, PCO2 of 72, and a PO2 of 54. So this is a sick patient who needs an intensive care admission. So these were the treatment measures that were given to this patient with COPD. So controlled oxygen, nebulized bronchodilators, IV antibiotics, oral steroids, prophylactic enoxaparin, so low molecular weight heparin. And this patient, a little while later, actually got worse. So the pH fell from 7.27 to 7.27. The PCO2 went up to 76. So the patient was then put on non-invasive ventilation at this stage. After an hour, the patient felt marginally better. The ABG improved with non-invasive ventilation, and 4 hours down the line, you can see the improvement. That's why non-invasive ventilation has a mortality benefit in patients with COPD. So you can see the pH has gone up to 7.36. The PCO2 has come down to 60 over a 4-hour treatment period. And over the next 3 days, this patient gradually got better, got shifted to a ward on day 5, and 2 days later went home, which meant a total stay of 8 days. And exacerbation takes out a lot out of the patient with COPD. It increases their mortality at 1 year, at 5 years, and hence trying to reduce exacerbations in these individuals is very, very important. Chairperson, can I have 10 minutes to talk about asthma? Yeah? Okay. So asthma, you heard a little while ago, is the commonest chronic respiratory disease worldwide. And look at those numbers, 358 million asthmatics worldwide, and that's the global burden of data. So 358 million, out of which 38 million asthma patients are in India. So 38 million, which is about 11.7% of asthmatics are in India. However, think about the mortality. 43% of people who die from asthma come from our unfortunate country. So that's why talking about asthma, management of asthma, treating them right is so very important. Show you some interesting slides before I come to this case. So this is mortality rate for asthma in 46 countries over a time span between 1960 to 2012. So a 52-year period, you're looking at asthma mortality. And I want you to see something. You see the spikes on the left. So on the left of the horizontal bar, on the left between 1960 and 1986, you see these large spikes of death. And then post 1980 till 2012, you see the mortality rate has come down. And that's not because we have better drugs. That's because we understand asthma better now. So previously from the 1960s, even when I did my medical school, I was taught that asthma is a disease of bronchoconstriction. It's a disease of airway narrowing where the smooth muscles contract and these cause symptoms. And hence, the treatment for asthma was based on short-term beta agonists. It was SABAs, which mainly treated patients with asthma. Then over a period of time, over a period of many years, the understanding improved, and we now understand that asthma is a disease of inflammation, and hence anti-inflammatory medication in the way of inhaled corticosteroids are your treatment of choice for asthmatics. So paradigm shift, bronchodilation being the main treatment of asthma, shift now to the fact that anti-inflammatory treatment, inhaled corticosteroids are your best treatment for asthma, and hence we treat asthma now with ICS. Any puff that an asthmatic takes should have an inhaled corticosteroid in it. If there's one message I can give the audience today to go back home, never give your patient an inhaler for asthma which does not have an inhaled corticosteroid in it, right? So that's one important carry home message. All asthma is life-threatening. So people perceive that mild asthma is not so risky, it does not cause deaths. Look at the numbers on there. These are patients with GINA-defined mild asthma. And you can see more than a third of patients land up with an acute attack, at least one acute attack in any given year. About 16%, so that's 1 out of 6 patients will have a near fatal attack of asthma, even with the background of mild asthma. And then 15 to 20% of adults who die of asthma actually have background mild asthma. So that's 1 out of 6 to 1 out of 5 patients dying of asthma has mild asthma. The exacerbating factors in our country are many. That's why deaths are so prominent. It's in the air that we breathe. Air pollution is one of the most important triggers. The PM 2.5 that we inhale on a daily basis across our cities in this country are the important triggers of asthma that we cannot help but breathe in. But there are other triggers to think about. Risks of SABA-only treatment, important to remember, short-acting beta agonists should never be used alone in the management of asthma anymore. And what are the reasons? The Sigma study from 2019 showed that SABA taken alone increased exacerbations and increased deaths from asthma by a relative risk of 3.2. That's one of the biggest relative risk for mortality increase in patients with asthma. So remember all of you, when you give your patients, if you give your patients a SABA as a reliever medication, you increase the risk of exacerbations and you increase the risk of dying early from the disease. This is what inhaled corticosteroids do for you. Inhaled corticosteroids reduce the risk of death. At the bottom, you see number of canisters of inhaled corticosteroids, and you can see if you're taking 12 inhalers in a year, that's 1 inhaler per month, your chance of dying from asthma is next to nothing. So you can actually prevent deaths in asthma if your patient is compliant to something as simple as an inhaled corticosteroid on a monthly basis. I've said mostly about what GINA 2023 recommends, but just very briefly, you can see that the reliever medication and the maintenance medication in asthma is the same in GINA track 1. I'll say that again. The reliever and the maintenance medication in track 1 of GINA is the same, something which is called single maintenance and reliever therapy or SMART therapy in asthma. If you look at track 2, there you have an ICS plus a SABA. So inhaled corticosteroid plus a SABA as rescue. You can take in track 1 your ICS formoterol on an SOS basis. When you have mild disease, step 1 and step 2, you take the ICS and the formoterol on an SOS basis. Thereafter, in both tracks, it's maintenance treatment. Just 2 more definitions before I come to the case. So difficult asthma and severe refractory asthma are 2 definitions that all of you need to remember. You don't need to remember them by heart, but you need to understand what the difference is between these 2 terminologies. So difficult asthma is when you are on maximal treatment, which is the maximum dose of inhaled corticosteroid, plus a LABA, but you have not corrected for things like compliance, technique, comorbidities, trigger factors, differential diagnosis, etc. So maximum treatment, but not corrected for these factors is difficult asthma. Maximal treatment, but corrected for all these factors. So you've corrected technique, you've made sure the patient is compliant, you've removed the trigger factors for the patient, you've addressed the comorbidities. If your patient's asthma is still refractory, that is severe refractory asthma. And Gina in 2018, for the first time, that's 5 years ago, identified 5 different classes of asthma: allergic, non-allergic, late onset asthma, asthma with fixed airflow obstruction, and asthma with obesity. I want you to remember 3 markers which are easy to do, cheap to do in phenotyping patients with asthma. So the first is total and allergen specific IgE, which proves atopy in individuals with asthma. So raised total IgE shows you that the patient is atopic. The next in line is exhaled nitric oxide, which is a marker for Th2 inflammation. You can go by the ATS or by the BTS guidelines. The ATS guidelines tell you that a phenol level of more than 35 shows Th2 inflammation. The BTS guidelines tell you that a level of more than 50 is Th2 inflammation. And then the last and the easiest is blood eosinophils. Blood eosinophils are a surrogate marker for airway eosinophils, and hence again, they are a marker of Th2 inflammation. So I'll finish off in 5 minutes with this particular case. I'll whiz through the case. So please listen carefully. It's something that will be helpful for you in your clinical practice. So this is a 36-year-old housewife who came to me from Rabindranath Tagore's native place. So Shantiniketan is where this lady resided. She had a long-standing diagnosis of asthma. She had no addictions, but her husband was a smoker, so she had passive smoking, no biomass exposure. She weighed 77 kilos and she had a BMI of 27. So she was in the overweight category, but not in the obese category. So remember, this lady was overweight, no other comorbidities. This lady had had a diagnosis of asthma for the last 12 years. So you remember, she was 36. She got diagnosed with asthma at the age of 24. And she had all through the year cough, wheezing, expectoration, allergic rhinitis symptoms, and sneezing. She was regular, and remember, this is one of the first tick boxes. She's compliant with medications. She uses her ICS-LABA religiously. Initially, she was on a dry powder inhaler, and now she's on a metered dose inhaler, and we ensured that she's always taken her inhalers on a regular basis with the right technique. Historically, she used to have 1 to 2 exacerbations per year, and her GP gave her a course of steroids. She got better, and she went back to her inhalers again. 2016, the penny dropped in this individual. So coincidence, the last patient was 2016, this too is 2016, but 2016 this patient required an admission to ICU, no mechanical ventilation. She was treated in an outside hospital, and after stabilization she decided to come to us as a referral from that hospital for further care. She was breathless and very unwell when she actually came to me in clinic. She did not come to the emergency. She came to clinic to see me. She was breathless, wheezing, lots of cough, phlegm, and we readmitted her because she was also hypoxic at the time of admission. This is an important slide, guys. This is how your clinical details should be written for your patients with asthma. So family history at the top, you can see she's got a positive family history. Asthma comorbidities thereafter. So this patient has allergic rhinitis but no nasal polyps. She has contact dermatitis. She's overweight. Remember, her BMI was 27. She has gastroesophageal reflux disease. And important to remember, she does not have depression, anxiety, which is one of the important coordinates, comorbidities that are important in asthma. Triggers. So those were the triggers: dust, cigarette smoke, apple, cold, strong smells. All of these gave her bronchospasm. They made her chest feel tight, and she became breathless. She was on triple inhalation. She was on standard good going treatment for GINA step 5, maximum dose of inhaled corticosteroid, a LABA and a LAMA, which she took religiously. She was also on Montelukast for allergic rhinitis, and she was on oral steroids when we saw. So we did these boxes: inhaler compliance ensured, inhaler technique checked, environmental triggers ruled out. She was overweight, so she had a sleep study done, and she did not have obstructive sleep apnea. These are the markers I told you about a little while ago. This is what helps us to endotype patients with asthma. So the serum Ig was very raised at 635. The absolute eosinophil count was 417. The exhaled nitric oxide was not available in 2016. And the lung function, and yeah, don't have a graph to show you, but showed moderate obstructive airways disease with reversibility. So it was consistent with the definition of, spirometric definition of asthma. This is an allergic sensitization test, and the top bit tells you that this patient was allergic to house dust mite. The allergy to candida is not significant, but it's important that this patient is allergic which is defined by house dust mite being positive. So that was the summary of this lady. Young lady with asthma, allergic rhinitis, GRD and obesity being comorbidities, frequent exacerbations despite good compliance and technique, poor quality of life because of her daytime and nighttime symptoms, and oral corticosteroids for the last one. So it's a question I was going to ask you, but you understand this patient has an IG which is raised, a eosinophil which is raised. So this patient is atopic on the basis of raised IG, is allergic on the basis of a raised blood eosinophil count. So the phenotype of this patient would be T2 high, overlap phenotype, overlap because both the IgE and the eosinophil is raised. So what is the next step? And to cut a long story short, you understand that this patient has a raised IgE, so you can give an anti-IgE to this individual, which in our country at that time was omalizumab, and this patient has a raised eosinophil, so you can give an anti-eosinophil drug to this agent, which can be in the form of an anti-IL-5 or an IL-5 receptor antagonist. At the time in 2016, there was only one drug available to us, which was omalizumab. So in 2012, we tried to optimize therapy by putting her on a triple, but then when we failed, we started on her omalizumab. She was good. She improved even though she did not come to normal baseline. She took the drugs for a year, and over a year, you can see on that chart, look at 2017, 18, and then beginning of 19, she was reasonably okay. Couple of exacerbations requiring oral corticosteroids, but no admissions. And in 2020 thereafter, the penny dropped and she became COVID positive and then had significant worsening of disease. So symptom control got worse, went to another physician because she thought coming to me, I would insist about MABs again. So she went to another doctor, given oral corticosteroid, given a steroid sparing agent in the way of methotrexate, for which there's no evidence in asthma. But I guess you cannot fault the other physician because there was nothing that you could do to control her asthma despite good compliance. And then she had a very severe exacerbation and landed up with us in the emergency. These were our numbers at the time. So IG is still raised, absolute eosinophil count still raised, pheno still high, and moderate obstructive physiology with reversibility. So practical problems in this patient, there were financial issues, no medical coverage, place of residence was away from the hospital, and lots of medical issues, symptoms, daytime, nighttime, psychological factors now to deal with. These were options that we academically, theoretically had. So restart omalizumab, try an mepolizumab or benralizumab, which had become available to us in 2021, and trying bronchial thermoplasty. But in our case, she couldn't afford anything. Thankfully, we had a trial for mepolizumab going on then, and we restarted on mepolizumab. The trial went on for a year. She was fine for a year. However, thereafter, again, she's admitted with me today as we speak in the hospital with a bad attack of asthma. So important to say that the effect of biologics will wane when you stop biologics or you wean off patients of biologics over a period of time. And there are these overlap candidates where you've got a choice, and I think you need to make that choice prudently because these are expensive drugs for your patients. I'll stop there. I think I've taken more than enough time. So I'll speak about ILD to this audience another day. Thank you very, very much for listening.
Sir. Okay, sir. Listeners are requesting you to just go ahead with your slides. That's the ILD.
So I'll take 5 minutes if it's okay. I mean, I'll have to take Dr. Pathak's. Yeah, so laga do yaar, please. So I'll take 5
very patiently, sir.
Thank you. Thank you. Okay, so very quickly, 5 minutes by the clock. So the incidence, so the prevalence and incidence data for ILD is far lesser as compared to what it is for asthma and COPD. This is the pan-European study. It's also got some countries in the Middle East in it, and it shows two different things. So this is the 2022 publication to which we also contributed from India with some cases. It doesn't show up on the slides because it was only our center which contributed cases. But this is a long list of countries which shows the incidence of ILD in these countries. And I want you to look at this slide, which is more important. It shows you the incidence, and on that side, the death rate. So on the left of the bar diagram, on the left is when the incidence is reducing, and on the right is when the incidence is increasing. And you can see all the bars go to the right, none come down on the left, which shows that both the incidence and the death rate in interstitial lung disease is going up precipitously. So very briefly, diagnostic delay is a common problem in patients with interstitial lung disease, be that of IPF or the non-IPF category. So that's an important thing. The ILD India registry, our publication from the ILD India registry from 31 different centers, showed that it took 4 years for the diagnosis of ILD, and you know the mortality from initial disease is about 3.5 years. So you understand why we never managed to diagnose our ILD. We would diagnose them, but we diagnose them only if they lived beyond 3.5 years. That's the challenge with ILD. Many patients misdiagnosed, given ineffective treatment, and a timely diagnosis reduces unnecessary investigations, and it improves outcomes in these individuals. So this is a lovely slide from Dr. Lamas, one of our colleagues in Europe, who shows that later the diagnosis, greater the mortality. Look at the orange line which plummets downwards. You can see that from diagnosis, about 60% of people with ILD would be dead by 4 years. So 40% of patients would actually be alive at 4 years if you had made a diagnosis of ILD beyond 4 years. So that's the result of delay in diagnosis. The reasons they are diagnosed late, in my understanding, is insidious onset of disease, non-specific symptom. These patients cough, these patients are breathless, and the symptoms are no different to what you would get in a patient with COPD, for instance, or an asthmatic, for instance. There's minimal symptom burden, there's scarce knowledge about fibrotic ILD amongst our primary care physicians and non-ILD experts, and there are few non-ILD experts in our country, and long waiting times at specialist center. So what do we need to do? So we need to think about ILD when you have a patient who has breathlessness and a chronic cough. It's not always going to be airways disease. It can also be interstitial disease or parenchymal disease. Listen to the chest, and I'll come back to that in a moment, but listen to the back of the chest carefully with your stethoscope, an art which is being lost gradually as we're going past. If you manage to hear crackles at lung bases, that's something which is almost diagnostic of ILD in your population of patients. Look at the fingers. If you get crackles and you're clubbed, the sensitivity for diagnosis, so crackles plus clubbing, the sensitivity for diagnosis is as high as 90%. That's most CT scans, that's sort of diagnosis in most diseases, whereas CT scan cannot give you. Incidental identification of ILD, we're doing a lot of CTs, especially in the post-COVID era. So you could incidentally find ILD on imaging, and interstitial lung abnormalities are septal thickening that you get with the aging process. You need to prone these patients. If these septal thickenings go away, then this is fluid accumulation. If they remain, these patients need to be followed up in the long term, because about 60%, so 6 out of 10 people will end up having ILD at a later age. This is from the European Respiratory Journal, Vincent Cotan. Lovely words, I think, very, very important for all of us to remember. The stethoscope is a genuine tool, probably the best tool for early diagnosis of IPF, the prerequisite for early treatment and improved long-term outcome for this dreadful disease. And this is something I want all of you to remember. It doesn't require a lot of money. All you need to do is to listen to the patient's chest. So look at quickly at treatment. And these are all the important trials that have been done in this area in the last 3 years. So 2019 till 2022, all important trials. And I want you to think about these trials with me. So 2019, this is the Distler trial, which looked at systemic sclerosis interstitial lung disease. So scleroderma ILD, and they found over a 52-week, 1-year period, the drop in the antifibrotic group, which in this case was nintedanib, was about 40 ml lesser. Sounds a small number, but it's a significant number, 40 ml lesser in the antifibrotic group as compared to the placebo group. So that's the first trial. The second trial is from Flaherty. This looks at progressive fibrosing ILD, and again, this showed a whopping 150 ml reduction of FVC reduction. So the FVC reduced less in the nintedanib group as compared to the placebo group in the non-IPF progressive ILD group. In Lancet, Toby Maher showed that pirfenidone does something similar in patients with unclassified ILD. So Toby Maher Imperial showed that in patients with unclassifiable ILD, if you gave these patients an pirfenidone, they would cause a significant reduction in the downward descent of FVC in these individuals. And then again, in Lancet Respiratory Medicine from about 2 years ago, the same effect was shown with pirfenidone in patients with PF-ILD. So lots of data that these patients are helped by an antifibrotic. Last 2023 trial, they showed 2 drugs, tocilizumab. All of you would have heard of this drug during COVID. This reduces FVC decline in systemic sclerosis, and treprostinil, which is a drug which is used more by our rheumatology colleagues, shows improvement in 6-minute walk distance and FVC in group 3 pulmonary hypertension patients with ILD. So that's the summary of all the trials. But I'll finish off talking to you about ILD with this slide. I want you to remember and understand this slide with me. So the red bar at the top is patients with fibrosis. So this is patients with IPF, patients who have predominant fibrosis. The blue at the bottom is patients who have inflammation. So at the top, patients with IPF is all about fibrosis. There's hardly an inflammatory component, and hence there you would prescribe an antifibrotic in these patients. If you gave them a steroid or if you gave them an immunomodulator, these patients die quicker. So never use an anti-inflammatory drug in that class of patients. Now come down to the non-IPF ILD category, the CTD ILD, the chronic HP, the unclassifiable disease, etc. And you can see a transition from white to blue to red. And there's an overlap that you see between blue and red. And you can see in these patients, when this predominant inflammation, as in predominant blue, you give these patients something like a steroid and a disease-modifying agent like mycophenolate or azathioprine, etc. And then when fibrosis sets in, you would prescribe these patients with an antifibrotic drugs. So when you look at these patients, think of the drugs that you give in these 2 different baskets, as an immunomodulatory drug and as a fibromodulatory drug. And you see a list on there on the left of drugs in development which you don't need to remember. But remember, when you're prescribing, make sure in your own head, ask yourself the question, does this patient have ongoing inflammation? If yes, they need steroids and immunomodulatory therapy. If they are fibrotic, if they have predominant fibrosis, think of giving these patients antifibrotic, and there'll be an important class of patients where there's both, and you would have to give all 3 drugs to these individuals. So that's my concluding slide. So the fact that we've got a massive load of chronic respiratory disease in India. COPD is the 2nd commonest cause of death. However, if you combine the 3 diseases I spoke about, which is chronic respiratory disease, so asthma, COPD, ILD, haven't spoken about bronchiectasis, also bronchiectasis, the cause of death, which is #1 globally and in India, is chronic respiratory disease by far. And you go back to what Dr. Rajendra Prasad was saying a little while ago, too little attention on respiratory disease and too much attention on other diseases is something which is a strong carry-home message from this particular talk. Classified diseases are being airways disease and interstitial or parenchymal disease. And then airways disease need to be subclassified, asthma, COPD, then the type of inflammation and the phenotyping that I showed you with my 36-year-old lady from Shantiniketan. ILD needs to be thought of as IPF and non-IPF, and then again non-IPF needs to be thought of as being progressive and non-progressive. And most important, irrespective of which disease, if you can diagnose the disease early, you're going to manage to treat these patients early and reduce a lot of morbidity and mortality that comes with the disease process. Thank you very much.
Dr. Dhar, thank you so much for this creating wonderful flora and fauna, knowledge of flora and fauna around here. Friends, a legendary academician with his academic vista is here for your questions, if any. Please. Yeah.
COPD exacerbation, needed ICU admission. You are given why oral steroid, why can't you try IV steroids?
The question is why oral steroids, why not IV steroids? So I agree with you. I think if you have a very sick patient, like my patient was, I would probably also give IV steroids. Just to say that from an efficacy point of view, the IV steroid is no better to the oral steroid. However, the reason we give IV steroids to these individuals mostly when they are very sick is because we worry about their absorption. We worry whether the patient is managing to swallow the pills properly or not. So all of those factors, I agree with you. In most of my patients also, I would give them IV steroids for the first 48 hours, but de-escalate rapidly and come down to oral steroids after. So point well taken.
Any other questions?
Absolutely. So question, very important question, and this is something which I should have said in my talk. So question is, should we continue the biologics for a very long time? The answer is a big yes. I mean, if you have no cost constraints, so when I worked in the UK, we had patients on biologics for 10 years. You know, so they would come, they would take an injection, they would be happy, they would go back home, and they would remain well for a very long time. The important thing with biologics to remember is you need to choose your patient well. It's not a magic bullet. It is a bullet which works like magic in the right patient, and that's very, very important. But in that category of patients, you need to continue long term. What happens if you stop? So that's also an important question, and that's been tried in various studies. There's a study which is called the INSPITAL study, which got published in 2021, where they found that 50% of patients, 50% of patients, after stoppage of the biologic for 3 years, you stop biologics after 3 years, the spike in exacerbations in 50% happens after 7.5 months mean. So these patients will exacerbate, but there's a residual effect which lasts for a slightly longer. Some people have tried strategies like alternate months or half the dose in the long term, but that's anecdotal evidence. It cannot be used for clinical purposes in day-to-day practice or in a lecture for that matter.
Raja, excellent talk as usual. And the question raised about the asthma. You know, asthma, I always say, from last 40 years I'm saying, it's a chronic disease. It's a probably lifelong disease. And what Raja said is very right. Whatever drugs you are using, even you are using the new biologicals and other things, probably has to be used for a very long time. And I say probably a lifelong time. But how much dose, how to reduce, how to this is an art and you have to learn. Thank you, Raja.
Thank you.
Sir, I have two questions, queries.
Anji.
First, the status of this dupilumab for type 2 inflammation in COPD.
Sure. So question, dupilumab in type Th2 inflammation. So dupilumab is probably the most effective mAb. So we don't have head-to-head trials, but if you look at efficacy, so FEV1, exacerbations, quality of life, Dupili seems to have the best effect. It seems to have the best effect in patients who have a raised eosinophil count, an IgG which is moderately raised, in patients who are obese, and in patients who have concomitant atopic dermatitis. So that's the patient population who seems to actually respond best to dupilumab. And if I had a choice in the Th2 population, in the eosinophil category of patients of Dupili, I would probably put most of my patients Dupili rather than Bepo and Benra.
And the status of this inhalational biologicals?
Yeah. So inhalational biologicals, I don't think we have data as yet, but that's exciting. The oral biologics are also areas where we are looking at. Unfortunately, the last oral biologic which Novartis was trialing came back as a negative trial, to the extent that Novartis has closed its respiratory division. They've made so much of losses. But I think this is a sort of a moving goalpost. Some of the trials are bound to be negative. However, most trials have shown positive results. Both the inhaled and oral area are exciting areas. Injectable drugs are difficult to convince patients for, along with the cost. And I think we need to watch out. We don't have information both about oral and about inhaled biologics as yet.
Dr. Raja, I have one question. Here. Yes. All right. I really enjoyed your talk. There was this about CLD associated with the type 3 pulmonary arterial hypertension. So what is the mainstay of treating this patient as a pharmacotherapy?
Yeah,
because alloprost, which works very well, but apparently it's not available in India.
Yeah.
What about the endothelin receptor?
So brilliant question. The question is group 3 pulmonary hypertension, which is chronic lung disease, pulmonary hypertension. What is the treatment? So The treatment, if I had to give you a one-line answer, I'll give you a three-line answer, but the one-line answer would be that none of the drugs which are pulmonary hypertension reducing agents should be used in group 3 pulmonary hypertension. That's the one-line answer. The three-line answer is, recently there's two drugs, one is Selexipag and the other is Riociguat, have shown some improvement in the 6-minute walk distance in patients with group 3 pulmonary hypertension, especially in the ILD-PH category. So it's not iloprost, but it's Selexipag, which is also prostacyclin analog, and Riociguat, which was previously licensed for group 4 pulmonary hypertension, which is chronic thromboembolic pulmonary hypertension, which has also been licensed for group 3. But these drugs should only be used in patients who have disproportionate pulmonary hypertension, as in they don't have a great reduction of FVC, but they're very, very symptomatic with their disease. They cannot walk 5 meters. Right, and they become breathless. So that's the category of patients where you see an FVC of say 70%, but a pulmonary artery, mean pulmonary artery pressure of 70, where you feel that these drugs would be effective. Mainly it's the treatment of the underlying cause.
So thank you so much for wonderful talk, and I am sure, yeah.
Excellent lecture, Dr. Rajadhar. If patient of the bronchial asthma having the absolute eosinophil count is more than 1000 and total IgE is more than 1000, you prescribe omazolone?
So that's a very good question. I'll give you a short answer. I can see Pathak Saab gradually coming on to me. So I'll give you a short answer. If you get a patient of asthma with a very high eosinophil and a very raised IgE, you think of another disease. Can you tell me which one that is?
Allergic bronchopulmonary.
Wonderful. So that's what you think about.
Syndrome.
Correct.
If patient having the short disease, there is a history of then Loeffler syndrome.
So there you wouldn't be able to give omalizumab for sure, because then you will have to weigh the omalizumab in kilos and give it, which no one can afford. You can go for an anti-IL-5 in those individuals, but that's only after you've excluded all the causes that you spoke about and more about raised eosinophil in patients with asthma, and you've made sure there's no other disease, and then you would prescribe then an anti-IL-5 in those individuals.
Okay. If patient having this problem, then how you diagnose the patient having the allergic bronchopulmonary aspergillosis or invasive aspergillosis? So many patients of the bronchial asthma presented with the bronchiectasis and not controlled by the maximum inhalation therapy and maximum therapy.
So for ABPA, what I do as baseline screening test is a IG for aspergillus. That's what I would do for baseline to screen for ABPA. I would of course look for the IG, the eosinophil that you've already looked for. I would do an IgG for aspergillus, that's the other test. For SAFs, which is what you're asking, I mean, invasive aspergillosis would be a very sick patient. You know, it wouldn't be someone who would walk into your clinic, it would be someone who's probably on a ventilator. So patients who have got SAFs, you would probably do a BAL in these individuals and see whether there's aspergillus, along with the other tests we spoke about. And you could do a BAL galactomannan in these individuals also, and if it's significantly raised, that also indicates towards SAFs.
If bronchial asthma patient,
we'll do the discussion outside. So Pathak Saab is
sure. Okay, sir. I think me along with all others audience will be waiting for your next oration, and please do come here again. We will have a lot of questions, and then.
Thank you, sir. Now I would like to call upon Dr. S.K. Pathak, sir, Organizing Secretary, to present memento to Dr. Rajadhar, sir. We'll be having email ID of Dr. Rajadhar, sir. Later on, we can discuss all the queries over there, I think, sir. Thank you, sir. Now, I would like to call Dr. Robin Dubey, sir, to present memento to Dr. Dheeraj Kishore, sir. I would like to call Dr. A.P. Singh, sir, to present memento to Amit Johri, sir. Dr. A.P. Singh, sir. V.P. Singh, sir, sorry. Dr. V.P. Singh, sir, sorry. Dr. Sir, A.P. Singh required. अब साक्षी का अब साक्षी का हाँ बढ़िया है Thank you all the faculty, sir.